So thank you, Dr. Bhaduria, for that kind introduction, and good afternoon, everyone. So with my presentation, I am trying to make it more clinical for you. So hope you like it. So at the outset, let us consider the anatomical basis, structural defect and functional mapping. Always when you see the center of the retina, it is marked at the fovea, and that is reflected in the center of the field. Whereas the optic nerve, which is slightly nasal, is represented in the slightly in the temporal segment of the visual field, whereas any defect on the temporal retina naturally gets reflected into the nasal step. So if you see this slide here, any defect, you see the nerve fibers, they are run in an arcuate fashion. If there is a small defect here, it can form a focal defect, or if there is a larger defect, it can form a focal defect here. So this is the concept of the glaucomatous focal defect on the visual field. Whereas if you see here, at the edge of the optic disc, if there is an injury or a damage, the entire arcuate fiber gets affected, and this is the typical nasal step that is formed in glaucoma. So if there is a horizontal demarcation, it is classical of glaucoma. If there is a vertical demarcation in the visual field, it is classical of neurological disorders. And if there is no demarcation, there can be a local cause, as I showed you in the first slide. So now, whenever you are trying to do a disc evaluation, this is the right way to do with either a 78D or a 90D lens or a 60D lens. Indirect disc evaluation is the way to go, and not the direct ophthalmoscopy, because it doesn't afford the stereoscopic view with the direct ophthalmoscope. So what are the parameters that you should look out for the moment you look at the optic disc? Number one, the most important as on today, I would say, is the optic disc size. You have to make a forced decision as to what is the size of the disc that you're looking, whether it is a small disc or a normal size disc or a large disc. I'll come to this as few slides later. Then the standard optic cup, the neuroretinal rim, which is the prime of prime importance, which is absolutely important to assess the health of the neuroretinal rim at the end of the day. Any vascular changes or any hemorrhage on the optic disc, hemorrhage will not look at you. You have to see and rule out an optic disc hemorrhage. Any nerve fiber layer defect, and last but not the least, peripapillary atrophy or chorioretinal degeneration. So let us move on. The optic disc size. If you see the spot size of a ophthalmoscope, direct ophthalmoscope, here you see the size of that. This is supposed to be a standard about 1.5 millimeter diameter. Here you look at is a small disc, whereas the same spot size here what you see is a large optic disc, and you know that 1.2 million axons pass through the neuroretinal rim. Next comes the optic cup. The optic cup disc ratio is a standard. The vertical cup disc ratio is more important. You need to see how much is the cup disc ratio in the vertical manner, and then any cup disc asymmetry you need to evaluate. And then the next thing comes the anisometropia. What is the size, again, between the two eyes, a larger disc in one eye compared to the smaller one in the other eye. Now, the relation, as I told you, how does optic disc size and the cup disc ratio correlate? If you see this normal disc here, you see this is a normal size disc, and about 1.2 million axons pass through the optic disc. Now you see this. This is also a normal disc. It's a normal disc of about normal size, and again, you know the 1.2 million axons are passing. And here, if you see, it is a large disc. This is also a normal disc, and you know that 1.2 million axons are passing through the optic nerve head of the neuroretinal rim. If you see all the three discs together, what is the lesson that we learn? That the cup disc ratio varies with the size of the disc. These are all the three are normal discs. This is a small disc, this is a medium-sized disc, and this is a large disc. So cup disc ratio on its own is not significant. Then large cup can be normal for a large disc, whereas a small cup can be abnormal for a small disc. So importance of varies with the disc size. That is the reason why the moment you look at the optic disc, make a forced decision whether you are looking at a small disc or a normal size disc or a large disc. And then you have to correlate it with the optic cup, and what stands out is that the it is only a surrogate for the neuroretinal rim. This correlation between the size of the disc and the optic disc cup is a surrogate for the neuroretinal rim. So what is important is the health of the neuroretinal rim, through which, this is the neuroretinal rim through which 1.2 million axons pass. Whether it is pink, whether it is pale, whether does it have a focal abnormality like a notch. The next thing important is the so-called isn't rule. Isn't rule means the inferior neuroretinal rim is supposed to be thicker than the superior neuroretinal rim, which is supposed to be slightly thicker than the nasal and the temporal. This is the typical isn't rule. If the isn't rule is obeyed, caveat here, the disc should be straight, the disc should not be tilted. In certain abnormal situations, isn't rule is not applicable. But as a whole, in a normal disc, whenever you're looking at it, if the inferior isn't rule is not obeyed, that can lead to a suspicion of glaucoma. Then the contour versus color cupping. If you see this, if I ask you what is the cupping in this, you might say this is the amount of cupping 0.6. But if you see the dipping of the vessel here, this is the contour cup. So the difference between the color cupping and the contour cupping, you need to make a decision. You see the dipping of the vessel, the bionetting of the vessel, the contour cup is almost near total, about 0.9 cup, which may not correlate with the color cupping. Color cupping can be less, but you need to see the vasculature, assess the vasculature, where the vessels are dipping, and get to know about the contour cup to come to a conclusion as to structurally what is the level of optic disc cupping. Then the vascular changes, the standard nasal shifting of the vessel, the bearing of the vessels. Once there is a loss of apoptosis of the neuroretinal rim fibers, there can be bearing of the vessels and bionetting of the vessels, where the vessels dip, take a sharp turn and dip into the cup. The hemorrhages, as I said, always try to look out for hemorrhages and rule out the presence of hemorrhages rather than the hemorrhage trying to look out to this thing. Next comes the nerve fiber layer defect. Generally, it is seen with the red free light. If you see the texture, the glistening retinal nerve for the fiber, the glistening thing, if that is lost, what I always say is the moment you have a look at the optic disc, you do a parikrama around the disc. The moment you see a loss of texture at the edge of the disc, try to look out and fan out into the periphery, and only then you will be able to make out the nerve fiber layer defect. It is very, very unlikely, and it is near impossible that in a normal 90D examination without a red free light to pick up a nerve fiber layer defect unless you see it carefully with the red free light. So if you see the nerve fiber layer defect here, it is like a dark wedge. It is touching the disc. You see a hemorrhage here, the disc is touching and then it fans out into the periphery. And as I said earlier, if you see the glistening texture all around the disc, here the texture is missing. From here you look out into the periphery, then it is that point that you try to understand this concept of nerve fiber layer defect carefully. If you see the color image here and the red free light here, it is very difficult to pick up this nerve fiber layer defect unless it is a red free light. Or you go around the disc carefully. If you see there is a loss of glistening texture here, then you go out into the periphery, fan out into the periphery, then probably you may be able to pick up the nerve fiber layer defect. The next thing is the peripapillary atrophy or the chorioretinal degeneration. What is this peripapillary atrophy? If you see generally, it is the central beta zone. This is the beta peripapillary zone, and then this is the alpha zone. There are two types, and this is very rare seen nasally or circumferential. This is generally seen. Peripapillary atrophy is on the temporal side. The one closer to the disc is the beta, and in the periphery is the alpha. If you see the alpha zone, it is peripheral to beta. This is the alpha zone. It is peripheral to the beta, and then irregular hyper and hypopigmentation can be seen in this zone. It is because of thinning of the retinal pigment epithelium, and this can give a relative scotoma in the visual field. Whereas if you see the beta zone is central to the alpha, and it is peripheral to the disc margin. It is because of marked atrophy of the RPE, and there can be visible choroidal vessels, and sclera can be visible. And naturally, when there is no RPE, literally no RPE, it results in absolute scotomas. Then last but not the least is the chorioretinal degeneration. Chorioretinal degeneration is not pathognomonic of glaucoma, but chorioretinal degeneration has the potential of suppressing the sensitivity of the glaucoma there in the visual field. There can be a diffuse suppression of sensitivity in the visual field. So these are the 7 things basically. The moment you look at the optic disc, make a forced decision whether you're looking at a small disc or a normal size disc or a large disc. Correlate it with the optic cup. What stands out is the neuroretinal rim. The health of the neuroretinal rim, whether it is pink, pale, or does have a local abnormalities like a notch, whether the isn't rule is being followed or not. Then comes the vascular changes. After vascular changes, rule out the presence of hemorrhage, and after that, look out for temporal crescent, alpha zone and the beta zone, and last but not the least, look out for chorioretinal degeneration, and this completes your examination of the optic clinical evaluation of the optic disc. The important concept is the JOS rules that you must all know. What the JOS rules say: until proved otherwise, all discs have glaucomatous changes. Look out for glaucoma. Glaucoma will not stare at you. All glaucomas have RNFL defect. Look out carefully. Make a parikrama around the disc. The moment you see a loss of glistening texture, try to fan out into the periphery and diagnose a retinal nerve fiber defect if possible. But it is very difficult to see in the normal, but in the with the red field light, you have a better chance of identifying. Then all glaucomas have disc hemorrhage. As I said, look out and rule out disc hemorrhage rather than the disc hemorrhage staring at you. And last but not the least, all myopes have glaucoma. Every myope suspect glaucoma, rule out glaucoma in all myopes. These are the JOS rules. And now let us see the structural and functional correlation, what all we have discussed about the optic disc evaluation. If you see this optic disc here, the size of the disc, as I said, the first decision that you need to make, here you see a large disc. The cupping is almost 0.7. The neuroretinal rim is pink. It is not, there is no focal abnormality, and it is symmetrical. It is that likely to be normal. So this disc 3 to 4 decades back was glaucoma, which is not the case now. Now, if you see here, this is a normal size disc. If you see here, there is a notch here. The inferior neuroretinal rim is thinner than the superior neuroretinal rim, and because of this notch, there is an early focal glaucomatous defect in the visual field in the superior nasal step. This is the way you must see. And if you see here, this is the color cupping. But if you see the dipping of the vessel here, the cupping is more in the inferior segment, because there is the isn't rule is definitely not obeyed. There is a definite excavation of the inferior neuroretinal rim, and that manifests as a dense superior arcuate defect. If you see this disc here, near total cupping, it manifests as a total suppression of, in the visual field. In such cases, do a central 10-2 program for follow-up for these patients. I'm completing. And this is the last slide. The chorioretinal degeneration, as I said, caveat here, it can be a cataract. But assuming that there is no cataract here, chorioretinal degeneration can give rise to a diffuse suppression of sensitivity in the visual field. If you see a temporal pallor, always bilateral temporal pallor, do the visual field. You won't be amused if you see a homonymous hemianopia. Thank you for your patient hearing.
Thank you very much, Dr. Mathur, for that very informative